Good evening, everyone, and welcome to tonight's webinar. We're going to go ahead and get started in just 1 minute. I want to give everybody else just one more minute to get logged in, so stay tuned and we'll get started shortly. All right, everybody, good evening, and thank you for joining us for tonight's educational webinar, Introduction to the Diagnosis and Treatment of TMD. This webinar was made possible, as you can see on the screen here, by Dr. Rondeau, Lee Larstone. The Academy of General Dentistry did a wonderful job in promoting this, and Officite is the sponsor. Officite is the official website provider of more than 45 plus healthcare organizations and is committed to providing you with education so you can succeed in your practice. Our goal tonight is to educate you on some key components that can help you succeed and just how impactful those elements can be to your online success. Before we get started, a couple quick items. You're going to get some PACE approved credit for this session. It's 1 CE credit. Lee Larstone runs point on that. Throughout the session, we're going to do some polls, and also we're going to administer a test at the completion, so we'll send a link out. You simply complete it, and it will automatically get you your CE letter. If you're an AGD member, make sure you put that in there, and then it'll be automatically posted. The dial-in, if you have any audio issues, let us know. The best experience is when you dial in. If you have any technical issues, go ahead and call GoToWebinar support. Right now, look at the right-hand side of your screen, or that console with GoToMeeting. There is a chat tool. So if some of you can go ahead and start typing in names in the chat tool and ask questions, we're going to answer as many questions as possible for you at the session. Dr. Rondeau's got a lot of great information. And then when we're done, what we'll do is, we'll take as many questions as possible, and we might even have an overtime session if we get some extras. But let's get to our presenter. We've got Dr. Rondeau. I'm going to go ahead and give the screen to, let's see. I'm going to go ahead and give the screen to Dr. Rondeau. Okay. And he's going to be presenting Introduction to the Diagnosis and Treatment of TMD. What you need to know about Dr. Rondeau is he's been teaching for 35 plus years. He's a general dentist. He's got 50 years in practice. He lectures 100 days per year. That's right, 100. He practices 10 days a month. He's got 5 diplomats and 3 in sleep, 1 in TMJ, 1 in ortho. And in general, he loves helping dentists from what I've seen. Action-packed session. So you're in for a treat. So at this point, Dr. Rondeau, I'm going to go ahead and turn the program over to you. So take it away.
Thank you very much, Don. It's really a pleasure to be here tonight, and I'm pretty fired up tonight because I gave this presentation 2 weeks ago, but I've improved it. So you're going to get the new and improved presentation. What is TMJ? All the patients know about TMJ. It really just means jaw joint. Okay, and what's TMD? TMD is temporomandibular dysfunction. So when you're talking to a professional, you want to say TMD. When you're talking to a patient, say TMJ. Tonight we're going to talk about acute problems. Acute things that happen in TMD are less than 6 months. Chronic is more than 6 months. I'm going to talk about how you treat an acute case and how you treat a chronic case. I really believe that TMD should be treated and diagnosed prior to ortho, restorative, or prosthetic dentistry. And the problem is our dental schools are not following that principle in many cases. There's only a few dental schools in the US and Canada that really teach or have TMD programs for the undergraduate dentists. The big thing is, do you use a night guard, and when do you use it? Because most of us in dental school learned only about this upper night guard. I call it an upper night guard or a flat plane splint. And that's what most dentists all over the world make for everybody, a flat plane upper night guard. I like to use a lower repositioning index splint. I like to put the jaw in the correct position and hold it there. See, if it's indexed, you can see that the teeth fit into these grooves here. Whereas if it's a night guard, they can just slide anywhere. And that's not right. We have to pick the position and put the patient in a position where they don't click in a comfortable position. Okay, so what's the role of the dentist? First of all, to diagnose TMD. Okay, so first of all, we should look at external derangement. That means problems outside the temporomandibular joint. And that includes muscle problems and clenching and bruxing. Okay, so if it's outside the TMJ, it's a muscle problem. Okay, and clenching and bruxing brings on those muscle problems. You can also have problems called internal derangement, which is within the temporomandibular joint. Is the patient clicking? Is it a chronic or acute closed lock? Is there crepitus? Okay, so remember, is it external derangement outside the joint or is it inside the joint? You have to make that determination before you can treat. Now here's an article which I'm going to give you at the end. And last 2 weeks ago we did this. There was a tremendous number of people who wanted this little 3-page article. So we're going to tell you how to get that at the end of the presentation. It's really good. I give it to my patients to read. The big problem is, look, 34% of the population, according to the American Dental Association, suffer from TMD. And most of us have received little or no training, and MDs get little or no training. Here's the scary part. The jaw joint was removed from medical textbooks after 1980, 36 years ago. So prior to 1980, TM joints were in the medical textbooks, and now they're not in there. So obviously the medical doctors are saying, look, dentist, it's your deal. You've got to handle it. Okay, so do we go a flat plane splint? When would you put that in? Now look at the upper night guard. Look at what happens here. Look at behind. If you have the patient bite behind these teeth, where do you think the jaw is going? It's not going forward, it's going back. If you remember one thing that I tell you tonight, you want to move the jaw forward when it clicks, and you don't move the jaw back, you move it forward. Okay? So when you have an upper night guard like this, what happens is the jaw goes back. Anytime you have a flat surface like that, the lower jaw goes back. And if the lower jaw goes back, that's very bad for the temporomandibular joint. And it can be devastating to patients who are clicking, because sometimes with this splint, they will go through a chronic closed lock. I probably get one patient every 2 weeks where the dentist has put a flat plane splint, upper night guard in, and the jaw has locked. Bad news. Okay, so again, I like this lower repositioning splint. It only fits on 4 teeth on the lower, 3 teeth on each side, two bicuspids and a molar, and it's an index splint. See how the upper teeth fit right into grooves. Now the patient can't go anywhere. That's the only position they can bite, and it's a comfortable position. Let's look at the anatomy of the temporomandibular joint. First of all, the condyle should be down and forward in the glenoid fossa. Have a look at the nerves and blood vessels back here. You don't want to compress those nerves and blood vessels. And the disc has to fit right here, anterior, superior, right there. Okay? If it's any other place, it's not in the correct position. It's not in the middle, it's downward and forward. The posterior joint space back here, distal to the condyle, because the ear's over here, is larger than the anterior joint space. The disc is about 2.5 millimeters thick, and that's where it's supposed to sit right there. If the condyle goes too far back, patients that have retrognathic mandibles, patients that have deep overbites, the condyle is routinely back too far. Okay, so if it's back too far, you're compressing the nerves and blood vessels. Fluid goes into the ear and causes all kinds of ear symptoms and all kinds of headaches. You don't want the condyle too far back. When the condyle goes back, the disc is seen here, which is biconcave in shape. The disc slips anteriorly. Then it's very easy to understand the anatomy. When the patient opens their mouth to talk or to eat, the condyle fits over the posterior rim of the disc, and there's a click. So if there's a click, that's a problem. That means the condyle is too far back and the disc is anteriorly displaced. Not good. So again, prior to TMD treatment, determine if there's an internal derangement. Is there clicking? Is there intermittent locking? Is it a chronic closed lock? What's going on? We must determine that. So in a normal situation, when the patient bites in centric occlusion, the disc is right here in the head of the condyle. When the patient opens, the disc stays in position. Patient opens, stays in position, it stays in position, and during closing movement, it's right there the whole time, acting like a cushion, and there's no noise, no clicking, no vibration. However, when the disc is anteriorly displaced, when the patient bites in centric occlusion, remember when the patient opens, they go onto the disc, and that's the click. They stay on, and when they go close their mouth, they go off the disc. So that's the opening click and the closing click. You must treat these patients before their jaw locks. So, anteriorly displaced disc in centric occlusion, condyle goes upon the disc upon opening and produces an opening click, goes off the disc when you close, closing click, and here's what you have to pay attention to. Stage 1 and 2 of internal derangement means disc displacement with reduction. That means the disc can be recaptured. Try to find out if the patient's in stage 1 or 2 of internal derangement. This is unbelievable. Clifton Simmons, who's one of the top TMD experts in the world, wrote several articles, and one of them he wrote, if you eliminate the click, you eliminate 94% of the TMD symptoms. That's amazing. Eliminate the click, 94% of the TMD symptoms resolve. So what's your objective? Eliminate the click. If you wait, you're going to have this situation. You're going to have the disc anteriorly displaced, stuck out there in a chronic closed lock. When the patient opens, the disc is in front. Patient opens, it's in front the whole time, and this is called a chronic closed lock, and this is very serious and very painful, and the patient has to be treated within 5 months. If the patient is not treated within 5 months, it's very difficult to resolve that without surgery. So you really need to get your patients to see someone who specializes in this if they can only open 30 millimeters. You're supposed to be able to get 3 fingers between the front teeth. If you can't get 3 fingers between the front teeth, there's a chance that you've got a closed lock. So the disc is in front of the condyle the whole time in centric occlusion, stays there, limited opening with locking, chronic closed lock, disc cannot be recaptured, and that's stage 3. My recommendation is to any of the dentists that are listening, if you have a chronic closed lock, get that patient referred to someone who specializes in TMD and don't treat those patients and get them there within 5 months. And of course, at the end of the road is this crepitus. This is where the head of the condyle goes up too far and perforates the ligament, and the disc is right out here in the front like this, and this is bad news. And the head of the condyle, instead of nice and round, has got this bird beak on it. So the nice thing is, though, that most condyles that I see are not like this. This is a very severe degeneration, and a low percentage of patients have that. Here's something you need to memorize, and it's in the article. The article that if you send for, talk to Lee Larson, we'll tell you how to get the article. Here's the 5 stages of internal derangement. You must memorize these and try to figure out which joint is what's happening in each joint, and it can be different. One joint can be clicking with no pain. The other joint can be clicking with intermittent locking and pain. Okay, so remember, if you have a patient in 1 or 2, I'm going to show you how to use a repositioning splint. However, to be honest, most patients who are clicking without pain don't want treatment. So your whole focus should be on stage 2, clicking with intermittent locking and pain. Stay away from jaw locking and severe pain, and stay away from crepitus and these others down at the bottom. Try to specialize right in this area here. And what's really neat is probably 80% of the patients that come to you will be in stage 2, clicking, intermittent locking when the jaw gets stuck, and pain. Try to prevent them from going down to 3, 4, and 5. Now, that's internal derangement. What about external derangement? Okay, external derangement is clenching and bruxing and occlusal problems. I'm not going to talk about occlusal problems tonight, but I'm going to focus on the clenching and the bruxing. Okay, so that's a TMD problem. The muscles are sore because the patient's clenching and bruxing all night, and these muscles are really sore. Okay, you've got a temporalis muscle right here, which contracts every time you bite your teeth together tightly, and down here you've got a master muscle, and every time you contract, that muscle contracts every time you close your teeth together and clench. So when patients come in, if they say, I've got a headache in the morning. If they've got a headache in the morning, you've got to realize they're clenching all night because the headache's right up here. That muscle is contracting all night, and that's why they got a headache. They also say, well, my jaw's sore here. So if the jaw's sore and the headache is up here, and they wake up with a headache, you can be almost positive that they're clenching all night, and you've got to make them an appliance to stop that. Here is an upper bruxing appliance. Okay? It's a night guard. It's a bruxing appliance. It's a flat plane splint, whatever you want to call it. Okay? It's supposed to stop the patient from grinding their teeth. Okay? But as I told you, it causes the jaw to go back, which is very bad for the TMJ. And this is unbelievable. In 1995, a long time ago, they estimated that the ADA recommended that there was 3 million of these splints made in the United States. 3 million. Because that's the only one dentists are trained to make in dental school. Now, look at the marks on this. Do you really think, when you have marks like this, that that's stopping the bruxing? No way. I mean, if you got marks like this, the patient's bruxing all night. Look at how can you make holes in a thing like that? And they frequently will grind right through it, and the dentist will make them another one. And this is serious now. I'm going to talk a little bit about sleep apnea, just briefly. Apnea is when you stop breathing for 10 seconds or more. Hypopnea is when your oxygen desaturates, goes down below 4%, which is dangerous. And AHI is how you measure sleep apnea, how you diagnose sleep apnea. So you take the number of apneic events and hypopneic events and multiply them together. Mild obstructive sleep apnea, the patient starts breathing 5 to 15 times an hour. Moderate is 16 to 30. And just so you know, we're allowed to make oral appliances for mild to moderate sleep apnea, which are most of the patients. Severe sleep apnea, they're stopping breathing over 30 times an hour. Now, those patients are in a lot of trouble. They got a lot of problems. So they did a study where they put these flat plane splints that we're putting in all these patients to stop their grinding. And the study showed that AHI, the apnea-hypopnea index, was increased more than 50% in 5 out of 10 patients, which means you're making people worse when you put in these appliances. Not only are you not stopping the bruxing, because they're bruxing more, you're also making their apnea twice as bad, and their snoring 40% as bad. So these appliances are really no good at all. You shouldn't make these appliances at all, and I can't believe that that's the only one that's taught all over the world. What is apnea? Okay, we're just going to stop this, just talk a little bit about this. That's when the patient lies on their back usually and blocks their airway, and they stop breathing several times an hour. Remember, over 30 times an hour is severe sleep apnea. Here's that, and we'll be happy to send you this article too. Here's a sleep apnea and cardiovascular disease. There's 450 articles here relating sleep apnea to cardiovascular disease. Heart attacks, strokes, atrial fibrillation, congestive heart failure, type 2 diabetes, of course, is also included. I mean, it's just unbelievable. Again, that's something I think general dentists need to learn about, and I know there's a lot of courses on that out there, and I have some courses also. Okay, what's the conclusion? It's not advisable to use a flat plane maxillary splint in patients who snore or have sleep apnea. International Journal of Prosthodontics, and yet we're making these and nobody's even checking for sleep apnea. We're not checking for snoring, we're just treating bruxism, and we're not treating it the right way. You're not treating bruxism the right way if the patient's grinding through the appliance. So I'll show you what I do, okay? That's what I use. Remember, I use the lower repositioning splint if the patient has an internal derangement and they're clicking, and I make the splint in a position where they don't click. Conclusion, mandibular repositioning splint will help reduce snoring and sleep apnea and may also be helpful to reduce TM disorders. So I'm very high on this one. I'm not high at all on that upper night guard. I just see no use for it at all. So internal arrangement, clicking, intermittent locking, you're going to use that repositioning splint. That's what you want to use. Now I'll show you what we do. Oh, here's something. I wanted to thank Officite because I've been with you for at least maybe 20 years. And I had 2 new patients today actually from the web. And in March I had a record month. I had 60 new patients, 33 ortho, 17 TMD, and 10 sleep. And Dawn, I want to thank you very much because you're doing a good job with my website.
I appreciate that. Thank you, Dr. Rondeau, very much. Yeah, to that end, would this be a good time to jump through and just give them a quick tour of what that exactly looked like? Yeah, so what I'm going to do is I'm just going to jump through really quickly and show you the type of program that Dr. Rondeau set up, and we're going to get back to the meat of the presentation here. But Officite, I mean, it's the whole reason Officite is around is because we just love, I love personally helping dentists like you succeed online. I love the innovation, how Google keeps pushing us to do more and be better. I love working at Officite for just the reason like Dr. Rondeau just said there. But the platform here is simple. I mean, it's easy. We make everything dentist friendly. So we've got a whole solution, top to bottom, website, SEO, online tracking, and we bring in some patient education so that you can have an impressive web presence. We build the website, we code it so Google, Yahoo, and Bing can find who you are, where you are, and what you do, and then you can be impressive online. We've got several clean designs that are very easy to use. We litter it with HD education and content-rich websites with 880 plus pages and a supporting article library. We leverage all the latest trends so that basically you know when your patients go online and search for you, you're going to see complete listings with great reviews about you. You're going to have an attentive team, and they're basically going to hopefully see their next doctor and dentist, which is you. So that's that said, I'll pass it back over. Just respectfully, so I know how to follow up with everybody, I wanted to do our first poll. And it's just let me know so I can professionally follow up if you would like Officite to reach out and do a free online effectiveness evaluation. So right now you should see a poll on your screen. So go ahead and just let me know professionally how you want to go through. And then we're going to do our next poll here. Is going to be on Dr. Rondeau's, and he's got basically a nice little, our first poll for the session. All right, so we've got about 60% in, about 10 more seconds. Good, okay. So let's go ahead and now let's do our next poll. And the poll here is going to be an upper night guard is ideal. Well, you can see it. Go ahead, answer the question, and I'm going to share the results with everybody.
An upper night guard is ideal for patients with TMJ problems. Yeah.
I'm going to pass the screen back to you, Dr. Rondeau. And so we've got 75% in, 80%. Perfect. Okay, let's go ahead and we're going to close this poll, and I'm going to share those results so you can see them on your screen. So there we go. Everybody got that one right? So 100% said false. So now, Dr. Rondeau, can you go ahead and can you show your screen again? I think you're on the waiting room area.
Lee, where's my screen here? Yeah. There, that one, eh? Okay, it's not changing here, but not changing. The screen, the slides aren't changing.
I see March 2016, 60 new patients. Is that the one?
Yeah,
Slide
if I want
44?
to get to that, I want to get the next one. I can't get there.
Okay.
We'll get there. So I'm going to show next. I'm going to show, I think, the night appliance that I recommend. Oh no, we're going to show acute closed locks. Okay, so what do you do when a patient comes in and they can't open their mouth? They can only open their mouth maybe 10 or 20 or 30 millimeters. This can happen, and it happened. I got another patient this week who had their wisdom teeth extracted and ended up with problems. It can happen, a patient goes for general anesthetic in a hospital. It can happen with whiplash injuries or trauma. Or pay attention to this one. If the patient is in stage 2 of internal derangement, they're clicking, and you put a distalizing appliance in and distalize that condyle with a night guard, they could go into a closed lock. Or if they're grinding their teeth too much at night, they can have a problem. Okay, so again, try to really pay attention to this one, because I see this happening a lot. Patients who click, get an upper night guard, distalize the condyle, and they get an acute closed lock. Not good. So that's the upper night guard I don't like. And I was so pleased that you all got that right. The upper night guard is bad news for TMJ because it caused the condyle to go too far back. So what do you do with an acute closed lock? So I'm going to show you an equalizer because somebody asked that question 2 weeks ago. And tongue depressors to unlock patients. Those are two things that all of you can do. I have two other methods to unlock. If those don't work, I use a distraction appliance, which an orthodontist showed me many years ago, and I manually unlock them. But don't worry about those two. I'm going to show you these two, which are easy. You can buy this equalizer, and I'll show you where you can buy it from. It's just a simple little appliance that goes in. It's full of water, and it moves the condyle a little bit forward, which is good, and it kind of relaxes the muscles a bit. Okay? Now they can't eat with that or they'll break it, but it's really easy, and there it is. So there it is. Just put that in, and that's the number 1-800-HELP-TMD. So that's on your screen, and I'd order some of those for patients who come in, and it's an acute problem, not for chronic problems. So it's a soft temporary splint filled with water, slight separation of the teeth, moves the condyle down and forward. Now, I had a patient yesterday who was locked, and all I did was put these tongue blades between her teeth. I started out with 1, and then 2, and then 3, and then sometimes 4, and all she did was move her jaw back and forth, back and forth, back and forth, back and forth, and she unlocked. The mother was so impressed. I actually had an in-office course with 5 dentists watching me, and I think they were impressed too because it was so simple. You know, so move the jaw back and forth. If the right TMJ is locked, then you want to move the jaw as far as you can to the left. So just move it away from the side that's locked, and believe me, the patient will tell you which side hurts, and they'll tell you which side locks. Plus, you open to the side of the locked jaw. So have the patient open slowly, and they open to the side of the locked jaw. Okay, now this is manually unlocking. We're not going to go through that tonight. So any information, I mean, we've got some courses and we've got some articles for you. Just call us, just email lee@rondeauseminars.com. So Lee, L-E-E, at rondeauseminars.com, or 877-372-7625. Polling question number 1. I guess we just answered that one, didn't we? Did that one. Upper night guard.
We did.
Right?
We did. Yeah. My apologies. I thought.
Yeah, no problem. No problem.
Flip the order
no problem. So I got a case for you now. I got a case for you. So let's show a case. Here's a 20-year-old girl with jaw problems. 20 years old, suffering from temporomandibular joint dysfunction. Okay. The first thing we do, we have to diagnose it. So we have to find out, is it acute or is it chronic? Remember, is it less than 6 months or more than 6 months? Does she have an internal derangement or external derangement? Is it a muscle problem, or is it a clicking jaw, or is it both? So we do a TMJ health questionnaire first, check her range of motion, and palpate her muscles. Okay. And this will be surprising to a lot of dentists because you've got a lot of patients that look pretty good. I mean, there she is. She's got a class 1 molar relationship, beautiful class 1 cuspid relationship, beautiful straight teeth, but she's got a bit of a deep overbite. And the thing you have to realize, it doesn't matter about the teeth. It matters about where the jaw is, where the condyle is in the fossa. It's a hard thing to think about, but that's it. So she's got a deep overbite. Most females over 20 that have a deep overbite have TMD problems. I would say it's at least 80%. I hope you're paying attention to that. 80% of females over age 20 with a deep overbite have temporomandibular joint problems. And she's got a bit of a short lower face side. That also will show that the muscles are too short and they need to be lengthened by opening the vertical. So, chief complaint, jaw pain. Wore a night guard for a year. Obviously, if it worked, she wouldn't be in my office. She got worse. Symptoms worse in the morning. What does that mean? Remember I told you that means she's clenching and grinding at night. Daily headaches. Headaches are the #1 symptom of temporomandibular joint dysfunction. Takes Tylenol daily and locks monthly. This is bad. If she keeps locking intermittently, she's going to get a chronic closed lock. She's got to be treated now. Here's my TMJ health questionnaire form now. That's the other thing you should write for. So write for a copy and we'll email that to you, the TMJ health questionnaire form. All dentists, general dentists, should use this on every single patient that walks into your office to determine if they have a pre-existing condition. And it's a real simple system because everything that's bad I circle yeses, see? And everything that's good I circled no's. There's not a lot of no's on that page. They're mostly all yeses. So look at this, a 20-year-old girl walking into your office. Are you missing this or are you catching it? Are you checking for ear pain, stuffiness in the ears, ring in the ears, headaches, front of head, clenching, bruxing, clicking jaw, pain behind the eye, jaw pain? How would you like to go through that every day of your life? Daily headaches. Look, daily headaches here. Who would want that? I mean, we couldn't function. So daily headaches, migraines, neck pain, jaw tired upon awakening because she's grinding her teeth at night. Teeth sore upon awakening. She's grinding her teeth at night. She had her wisdom teeth extracted. That's what caused the problem. I think she was in an accident waiting to happen because her jaw is not in the right position. But I think the wisdom teeth just did it when she had to open too wide. So all dentists also should do range of motion on all your patients. So if you just do those two things, TMJ Health Questionnaire, and we'll send you that if you email us, lee@rondeauseminars.com. And then you can run those off with colored paper and show your patients range of motion. As you know, you should open 50 millimeters, which you can do. Her right lateral is 11, her left lateral is 11, protrusive is 9. So she's actually got a normal range of motion, which is surprising because normally someone in that much pain, the range of motion is limited. Now down here is the muscle palpation. I'm not going to go through this in detail tonight. We teach that in the course. But if we palpate a muscle and there's no pain, it's a 0. If it's uncomfortable, it's a 1. If there's pain, it's a 2, and severe pain is a 3. And look at her. Look at all the 3s and 2s she's got. This poor girl is in bad shape. So when you clench and you grind your teeth at night, you're aggravating the muscles of mastication, and you're having pain upon awakening, and they're sore upon palpation. Okay, so the pain will be right here in the temporalis muscle, down here in the master muscle. Check those areas if the patient is clenching and grinding at night. Okay, so if you have sore muscles, it could be an intercapsular problem because the condyle in the wrong place, too far back, or it could be a displaced disc anteriorly, or it could be extracapsular problems from clenching and bruxing. So muscle problems can come from intercapsular or extracapsular also, but always from extracapsular. Okay, the referring dentist made her a night guard. I'm going to show you what he made her. He made her a flat plane splint, which distalized her lower jaw 5 millimeters. Look at that. That's a flat plane lower splint. Doesn't matter if it's flat plane upper, flat plane lower, they're both bad news. Okay, and so her jaw went back 5 millimeters. And remember I told you, if you want your jaw forward, not back, forward, not back, that's the lower night guard. Okay, and he did his best. I mean, that's what he's taught to do in dental school, make a night guard, and that's what he did. So there's no relief of symptoms. Any relief of symptoms, she would have stayed with that. She wouldn't have come to my office. Now here are tomograms. Again, you don't have to have these to do TMD. I have the machine, so I use it. The condyle is too far back. This space is much too small, and there's no space up here for a disc. So there's see, and you remember the posterior joint space. There's the ear, that black circle. Here's the patient biting in centric occlusion. And the circle, remember back here is where the nerves and blood vessels are. And the disc has to fit right in here. There's too big a space. So that disc is not in the right position. So remember, with your TMJ x-rays, your CAT scan or tomograms, the condyle has to be down and forward, not up and back. Not back, forward. That's where you want it, right there. The posterior joint space bigger than the anterior joint space. The disc has to fit right in here. So I have something in my office. Again, you don't have to have this. I love it. It's joint vibration analysis. It tells me exactly what's going on in each condyle. I know what's going on there and there by doing this simple little test. Okay? So the vibrations on the right were 15. The vibration on the left were 16. And we did a little test in the jaw, and the one side ended up normal, and the other side was mild degenerative joint disease, which means she's got a displaced disc. And so I show the patient this picture, and this is something you've really got to think about. When you put a splint in this patient, many, many times over 4 months, the jaw will go to a different position which is more comfortable, and you'll end up with a posterior open bite. The posterior open bite is not due to an intrusion of the teeth with that splint. The posterior open bite is due to the condyle moving down and forward and new nerves and blood vessels forming distal to the condyle. So I charged $4,200 for splint therapy, 2 splints, and the patient was, I think one of the other kids were a patient of mine, so I gave her a discount of $500 for payment in advance. So she has both an internal derangement, because remember she's waking up with sore teeth and with headaches, and she's making noise with the joint, so she's clicking and she's got an intermittent locking. So she needs 2 splints. Now this is what I want you to do. When you have the patient sitting in your chair, I want you to put a tongue depressor between her teeth. And I want you to put your fingers in her ears. And I want her to open and close and try to find a position where she doesn't click. Sometimes you have to move the jaw a little bit forward. Sometimes you have to put 2 tongue depressors in. But you want to find a position where they don't click. Because remember, 94% of the time, if you get rid of the clicking, you get rid of the symptoms. So she's biting up and down, and she should be looking in her mirror. She's not looking in the mirror now. She's supposed to be looking in that mirror so her jaw doesn't go back. So you put the tongue depressor in and find a position, either moving the jaw forward or increasing the thickness of the tongue depressor where she doesn't click. Remember, Clifton Simmons says, eliminate the click, 94% of the symptoms are resolved. It's unbelievable. I found the same thing in my practice. And again, I can send you his article if you request it. It was published in the California Dental Association Journal. So have the patient look in the mirror. My fingers are in her ears. She's holding the tongue depressor with one hand, and she's holding the mirror with the other. I wish it was, it's so simple. It's so simple. That's all you have to do. Find a position where they don't click and make the splint there. Then I show her. Now we put in 2 tongue depressors here just to show you, and there's the space between your posterior teeth. And I say, look in the mirror. That's where we have to put the splint. All I have to do is support your jaw in that position, stop the clicking, and you got a 94% chance of getting better. Wow. So we have to take a bite registration. I haven't got time to talk about how you do it today, but we take a bite registration. Well, I just told you, take it where they don't click. And then put some triad here. And then I'm going to fill that in with polyvinyl siloxane. So this is for the repositioning splint. Okay, you put red lines on the teeth so she comes straight forward, so her jaw doesn't go to the right or left. And then I put an L on the left, and that's the splint. That's the lower repositioning splint. It's an index splint, covers 2 bicuspids and a molar. It's got a gel bar, it's very strong, and it's very small. They can talk very easily with that. We don't cover the second molars, because I talked to her and she said, I would like to go to braces next. So I don't cover the second molars. I want them to passively erupt. So there we are. We got the splint, index splint, like I showed you, only covering 3 teeth on each side. Remember, the second molar is free to erupt. It's got 3 ball clasps on each side. The lab I use is called 5-Star Ortho, and I'll show you in a minute their phone number. So remember, she's like this, and she's in pain here. Headaches daily, earaches, ring in her ears, all kinds of problems. And that's why, because when your jaw's back, your disc is displaced, and you're pressing on the nerves and blood vessels back here. Okay? So that's where she is in centric occlusion. Her posterior teeth are correct, but the joint is wrong. The disc is out of position. So you put the splint in, and you're going to fix that problem. Remember, you don't cover the second molar. The splint only covers 2 bicuspids and a molar. And here is what happens when you have your splint in. You've got a posterior open bite down here. Actually, the splint covers that area. The condyle moves down and forward, and the disc goes back in position. And that's where you're going to treat. You're going to treat with the disc in position. You're not going to treat with the disc out of position like here. You're not going to treat anybody when they're clicking. You're going to resolve the clicking, and then you're going to treat the patient prosthetically, orthodontically, or restoratively. Please, it's such a simple thing. You have to do that if you want to really make your patients healthy. I mean, how can you bring a patient like that in and ignore the temporomandibular joint, which is happening in most offices all across the world, because most dental schools are not teaching this. This is simple. Okay, so here's the condyle when the patient bites in centric. Here's the condyle when the patient has a splint. Look at the big space distal to the condyle. Okay, but you don't have to take an x-ray if you don't want to. If you don't have the equipment, don't worry about it. Just put the condyle where they don't click. Okay, so here's the before with a small space distal to the condyle. Here's the after with the large space distal to the condyle. I mean, it's not rocket science. Put the jaw down and forward and make room for the disc to fit right in here. Same thing on the other side. Put the condyle down and forward and the disc fits in here. Polling question number 2. What do you got there?
I think we already did this one, Dr. Rondeau. This was whether or not you wanted to participate in the Officite free demo.
Oh, okay.
What I'll do is I'll throw a little link to the Officite's demo portal as well. If you want to go in there, there might even be an offer for some sort of free setup, which is pretty exciting. But I'll go ahead and put that in the comment right now. But let's just continue with your session.
I'm going to say one other thing about you. You've been coming to my courses for at least 15 years, and I've recommended your service to hundreds of dentists. Not one has come to me and said they regret their decision to go with you. Not one. And that can't be said, well, it can be said with maybe a couple of other guys that have come to my course over the years. Sold them TVs that eventually didn't work or things, but nobody has said they wasted their money or their time going with you. Everybody's happy with you, and that's why I'm having you lecture at my convention this year in Vegas, and I have you come to all my courses.
Well, we appreciate that. Thank you so much, Dr. Rondeau.
Oh, you're welcome. You've helped me a lot. Okay, let's talk about clenching. What are you going to do about clenching? Okay, you're going to have to take a bite registration, and it's very simple. Open 4 millimeters in the front. Okay? Remember, she was clenching, waking up with headaches. So this is something brand new. It's called a McKenzie gauge, and this is phenomenal. This is what I use today. Now, that's obviously a different patient. I use this now for all my bite registrations. Okay? All my splints, all my snoring appliances, everything. So you're going to put that in. What I like about this gauge is you can pick the height. You can go up to 8 millimeters in height and 8 millimeters forward or back. It's unbelievable. And you bite right in those grooves there and those grooves there. You pick the bite, put that elastic on so they won't move, take your bite, and it's perfect every time. And that's where you get it. 5-Star Orthodontics is the lab that I highly recommend in the U.S. that you deal with. Bobby Middle is the manager, and that's their number, 1-800-521-2351. Again, call our office if you need any more information, but this thing is fabulous. This has just changed my practice. Remember that you've got grooves here, so the teeth bite right in those grooves and they can't move. So it's perfect. So here's the appliance. That's the Ferrari night appliance. That's my design, and it only contacts the 4 incisors. Now that needs to be adjusted because she's only hitting here a little too heavily. So I'd go in with articulating paper and adjust that. Sometimes my staff will take the photos before I come in the room. The big deal is the posterior teeth don't touch. Posterior teeth don't touch. You can't clench. And it has a ramp. It has a ramp to keep the jaw forward at night, and it's got an air hole so they can breathe. This is phenomenal. Okay, so there's a ramp right there. So all night long, their lower jaw can't go back. Remember, we have to keep her jaw forward. We saw that because she was clicking. We saw that because her condyles were too far back in the x-ray. So that's what we've got to do. So there she is wearing her splint, and she's got this big posterior open bite. Okay, and remember, when you've got a posterior open bite all night long and your posterior teeth don't touch, including the cuspids, no contact on the cuspids, okay, your masters and temporalis can't contract, and you don't get headaches, you don't wake up with sore muscles, you don't, and you're just so much healthier. You're happy. Your muscles won't be sore like hers were. Remember, her sores were almost all severe pain when I touched them. So again, you can get these splints from 5-Star Ortho. I would call Bobby Middle. He's the president. He answers the phone most of the time. They've got about 40 technicians. They're in Dallas, Texas, and they're fabulous. They come to all my courses, all my TMJ courses, all my ortho courses, all my sleep courses. Okay, there it is. That's the Ferrari night appliance. It's got 4 ball clasps that hold it in. It's got this ramp which keeps the jaw forward. It's got that air hole so they can breathe. Okay, so here's the article we'll send you at no charge, okay? So Lee will email that to you, and then you can show it to your patients, and I give that to all my patients. Remember, 34% of the population is TMD, and very few of us have been properly trained to treat these patients. If you start treating these patients, you will be busy. You will be very busy, and your patients will love you. That's why I've been doing this 50 years, and I'm not going to retire, because every day I get people thanking me and hugging me, and they've been in pain for years and years and years, and all I do is put these two splints in. All I do is put this repositioning splint in, which holds the jaw forward and prevents the clicking, and I put the night appliance in like this, and that prevents them from clenching and grinding at night. Now, one quick thing. If the patient comes in and they're only clenching and bruxing, and they're not clicking, they only get this one. They only get the night appliance. They only get the Ferrari anterior deprogrammer, okay? However, if they're clicking, they get both. Because if you're clicking and you wear this at night, you will clench on that all night and cause problems. The other thing I must tell you, if you just clench and brux, that will not cause the posterior open bite you're going to see in a minute. But if you wear the two of them, there's a chance that you could have the posterior open bite. Again, please memorize these and try and figure out where your patient is on both joints, whether it's stage 1, 2, 3, or 4. Find out where they are. These patients in stage 1, clicking with no pain, just warn them that if they start getting into symptoms to come right in and get treated. But most patients in stage 1 are not going to give me $4,000. And I don't usually treat those. I wait till they get to stage 2. Okay, so there's the night appliance, there's the day appliance, and we talked about that. Okay, so there's the email address to get the article, lee@rondeauseminars.com. Okay, it also has on it, I guess it doesn't have it on. Okay, it's got the 5 stages of internal arrangement. So I do have my course online. So if you like online, you can take it online. It's normally $12.95, but because you're AGD member, and I've been a member so long, they gave me a free membership. I'm not sure if I've been a member for 30 years or 40 years, but anyway, now I have a free membership, so I encourage you to stay with the AGD, and because they're a wonderful organization. So you save $400 if you want to take it, and 20 CE credits, so 20 hours. 20 hours of cases on that TMD diagnose and treatment. Okay, so there's the Ferrari night appliance when they clench and grind. There's the repositioning splint to prevent the clicking and prevent them from locking. Now, here's what you have to know. You're going to get a posterior open bite. You have to expect that because the jaw now has moved to a more comfortable position. They've stopped clicking, and that's what they look like. Now, you have to deal with that posterior open bite. They either have to stay wearing that splint, which they can do. If it's a university student and have no money, I keep them in the splint. Okay? Clifton Simmons says the posterior open bite is normal. Okay, and we can give you an article to prove it. Okay, and he published in the California Dental Association Journal. Okay, so I mean that's an excellent article. So he and I do the same technique: repositioning splint for the day and the anterior deprogram at night. But expect that posterior open bite. You're going to see it, and tell the patient ahead of time they're going to get it. But remember, with just the night appliance, they don't get it. They only get it if they wear the day appliance and the night appliance for 4 to 6 months. But that means they're getting better. Now look what's happened here. My second molars have erupted. So the splint was covering the 2 bicuspids in a molar. Second molar is passively erupted. So even if she forgets her splint, takes it out and forgets it, I get those second molars supporting the jaw in the right position. So that's what you want to do. Okay? So what's the solution for the posterior open bite? Orthodontics is what most of my patients go for because it's a permanent solution and the least expensive. Crowns is another one. If they got badly broken down teeth and a small space between the teeth, you go crown and bridge. Overlay partial denture and something brand new, the acetyl rosin overlay. That's like, what do you call it? I can't remember now. I'll think of it. But that's something we're doing also. But most of the patients want a permanent solution. They want this. Okay, so you have to give them these forms, and again, if you want copies of these forms, anything you see on here, just ask us and we'd be happy to send it to you. Every month when they come in, you've got to do a progress report. So she's 4 to 5 after 6 months. 4 to 5, no pain medications. Therapy is helping her. She's not perfect. We're not 5 out of 5, but we're 4 to 5. Remember, daily headaches. She said I get a 90% improvement. 90% is pretty good. Very rarely do I ever get 100%, but she's 90%. Mild ear pain, mild fatigue, mild jaw pain, pain when chewing, some headaches, but not much. It might be a monthly headache, which is regular. So anyway, that's the forms we fill out, and she says, I want to go ahead. So I say, here you had, came in with a splint, now we get this posterior open bite. Let's do orthodontics and close it. Okay, so I do another joint vibration analysis. Here was the original one, the pre-treatment one, which had mild degenerative joint disease. And now she's got normal. Now there's no clicking. I now know the jaw is in the right position. Again, if you don't have the joint vibration analysis, highly recommend you talk to BioResearch, is the name of the company, BioResearch out of Milwaukee. You can call us for the number. Highly recommend, and if you take my course, of course we have that demonstrated at the course. It's a phenomenal device. It's been used for 25 years. I've had it for 25 years in my office. Okay, so when she first came in, the vibrations were high at 16 and 15, and after with a splint they went to 5 and 5, which is normal. Okay, so there she is. I've proved it with the joint vibration analysis. If you don't have the JVA, I want you to put your fingers in your ears and make sure there's no clicking. If you have an x-ray, you take it, make sure the condyle is downward and forward. She had TM dysfunction. Now she's happy. Now we're going to go for ortho and make her permanently happy. Okay, so I do have a TMD course in Washington on the 3rd and 4th of June, Friday, Saturday. The fee's $10.95. I'm willing to give AGD members $300 off, which is $7.95. Again, call if you're interested. Love to see you there. The big advantage, I think, is you're going to see probably 6 or 7 cases start to finish, but you're going to get a course manual with 360 pages. It used to be TMD for dummies, but really there's a lot of information there. So 360-page manual. You can spend a nice summer reading that. You take the 2-day course, you read that manual, you're going to know what you're doing, and you'll be able to treat the simple cases. And you'll know what cases to refer out. Remember, stage 2 of internal arrangement is an easy case. And then I charge her $6,500 for ortho, okay, which is really easy. Really easy, okay? So I'm going to keep the lower repositioning splint in and start, and she wanted clear braces, and I'm going to start erupting the teeth one at a time at the back. So those marks will come off. She wanted clear braces, and so they'll come off, but look, that second molar is up. Second molar came up on its own. Okay, the splint only covers 3 teeth, so she can talk, she can eat. So we put a nice wire in the top to level out the upper arch. And then we're going to start erupting the teeth. Polling question number 3.
Here we go. It's going to be, let's get this up. Okay, the treatment for a patient who has a clicking jaw is a lower repositioning index splint. True or false? Let's go ahead and start answering. So we got 4% in, 7%. And this is going great. So we're going to go a little bit longer here. We've got some questions and answers coming on too. So go ahead. I've already got a ton of questions. So what we're going to do is we're going to answer as many questions as possible. And then, Dr. Rondeau's he's got a couple more slides here. And then once we start the questions and answers, I'll let you know when the hour's up, and we'll get you the CE thing. But frequently, Dr. Rondeau's been kind enough to keep going and answer the questions to get everybody satisfied. All right, so we got 77% in. So let's go ahead and close the poll and show the results. And right now we have, 90% said true.
Very good. Very good. You have a very bright group tonight. Okay. I know I apologize as I'm talking fast, right? I'm trying to give you as much information in an hour as I can. I'm not trying to hold anything back, but obviously in a 2-day course, I go a little slower and we give you a few more details, but I honestly think if you use that repositioning splint for a patient who clicks and make it where they don't click and index it, you're going to get unbelievable results and you're going to love helping patients. Can you see this slide now, Don, 152? Okay,
I do, yes.
Okay, good. So now the patient developed some few symptoms, and so I had to reline the splint slightly. So I just opened the vertical a little bit more. So you can see there's a space between the front teeth now. So I just opened her a little bit more to give her a little, she's slightly more comfortable at this position. So again, I relined it with triad. Now where's the, down here I guess. And there's the lower splint, relined with triad, and there's the Gelb bar, Harold Gelb's bar, and there's the repositioning splint. Remember, it's index. See how they're biting into grooves? It's not flat. Index splint. You pick the position. I tell the patient, if you break your arm, do you put a cast on that slides around, or do you put a cast on that holds the bone secure until they heal? And then the patients kind of understand, you're right, I need this splint. The other one didn't work. Okay. So again, we're almost done. I just want to show you what we're going to do now. We're going to erupt those back teeth. Okay, because we opened the vertical a little bit, all I can tell you is this patient here with almost what you would think is a perfect bite was in intense pain, headaches every day, and when I put her in this splint and just opened the vertical and just put the jaw in the right position and got the disc back in position, no pain. Same thing, pain, deep overbite, open the bite, no pain. Okay, so now you can see the teeth are lined up. It's kind of interesting. She asks for clear braces and then she puts these colored ligature ties on because we have clear ligature ties we could have used. Anyway, then I put brackets. We're almost done. Put brackets on the second molars, okay, because I opened the vertical a little more and we have to bring those up slightly more. And there she is. Nice. Now she's got beautiful colored ligature ties. That's better. Looks like Easter. And then we've got an elastic going from the molar on the bottom to the molar on the top. And that will bring that lower molar up, okay, and it's painless, okay? And they have to put it on so she can talk. So she can talk, and that's when it's stretched open, and there she is when it's not, when her mouth isn't open. So when she's in rest position, it's like this, and when she's talking, it's like this. And the tooth will just come up gently. So just put a bracket on that too. So what we're doing is we're going to bring them up one at a time. Okay, so I'm going to bring this tooth up, and then I'm going to cut the first molar off, and bring that tooth up. And then I'm going to cut this off and bring that tooth up. And I'm going to bring them up one at a time. I'm basically replacing the splint with teeth. It's quite a simple concept, which my patients understand. And it's different from the way some people do it, but it's the way I do it. And I think there's probably about 15% of the orthodontists in the country and many, many GPs have taken my courses that are doing this. So this is what we do to finish an orthodontic case when we find the right position with the lower repositioning splint, okay? Erupt that lower second molar. Again, there's the elastic. Bring it up. Pretty easy. The patient just puts that elastic on, takes them off to eat, brings the tooth up. When that's up, we're going to bring up the next tooth. Okay, and they pay me well for this. Okay, so almost done. Repositioning splint is a temporary solution. If the patient has no money, they stay with this. If the splint wears down, we add to it, add the acrylic, and build it up again. I've got some patients been in splints for 5 or 6 years. Every year they come in, we add a little to the top of it, and they go back home and they're happy. However, it's a temporary solution. I tell my patient this is a temporary solution. The permanent solution is replace the splint with teeth. Such a simple concept. Grind down the splint, bring the teeth up to the same position where the splint found they were pain-free. How easy is that? But orthodontics is the best way to do it. As I say, you could use crown and bridge. If the teeth are badly broken down or there's some missing teeth, I send them to my general dentist friends and they do crown and bridge. Okay, so again, that's her. TM dysfunction, headaches every day before pain. Here she is, happy patient after pain. She's going into braces, and I'd like them to have that nice smile. So again, there's the Washington course, just to repeat it for a second. June 2nd, 3rd, and 4th. Call Lee if you want to attend. Love to have you attend. And there's the book. Remember, the book is 360 pages, all about TMD, and colored pages and colored splints and cases from start to finish. I really think you enjoy the course. We actually give a money-back guarantee for all our courses, and we've never had anyone ask for their money back for TMD and not for the sleep. And I did have a couple of early treatment mixed dentition courses where a couple of patients asked for their $275 back or something, but never on the full course. So again, you have a money back guarantee. If you don't like it, I'd be happy to let you keep the manual, and we part friends. Again, call Lee at rondeauseminars.com. And Don, I finished on time. I can't believe it. I added 25 photos, and I actually finished on time. I can't believe it.
Well, we appreciate that, Dr. Rondeau. That is fantastic. So this is the point. I mean, you've been in the hour. You're eligible for the CE credit. So I'm going to go ahead and I'll pop up that survey right here. Also, when you're done, you're going to get that notice as well. We have got tons of questions coming in, so keep them firing in. We're going to keep going for all you overachievers tonight that want to get even more. We're going to ask and answer these questions. But just in case you are, you do have to go, I just want to thank Dr. Rondeau for the great information. Thank you, Lee, for all your help in putting this together. Thank you, the AGD, for helping promote and this course. And everybody else, if you want some help with the web presence, Officite would love to help you. I would love to help you. That offer's out there. I put the link on the side. We would take great pride in representing you online. So with that said, you can reach me, Don McKenzie, at webinar@officite.com. You can remember Mackenzie, Don McKenzie at webinar@officite.com, and I can schedule an appointment. And we'll just get it set up. I'll give you a quick 10-minute evaluation, let you know what I think you should do online, your quick 5 wins, and then we'll go from there. No obligation, and you'll at least get benchmarked to your peers. With that said, let's get to the questions. Oh, actually, okay, I'm going to copy and paste right now the link for the test into the session. So go ahead, and on the right-hand side, you should see the test, but don't leave. You can do that while you're listening, right? So Dr. Rondeau, are you ready for some questions?
I'm ready.
All right, let's do this. We have a ton. This first person that says waiting for, I don't have their name, but I'm going to say everybody's name so you can understand who's asking the questions. It says, but the first person wants to know, are we going to get the slides and the presentations access? So yes, housekeeping, Lee Larson, Lee at rondeauseminars.com. She's going to have all that support collateral for you, whether it's the TMD handout or just some notes or information. She's your gal. Next up, Dr. Harmon, can you use clear liners to set the teeth after using a repositioning splint?
Oh boy, clear aligners, Invisalign or clear aligners can cause temporomandibular joint dysfunction. It's acting like a flat plane splint, and that's amazing to me. I mean, if you have a patient who clicks, don't put a clear aligner in, don't put a night guard in. Now, after you get the jaw stabilized and you want to use a clear aligner, that's fine. But if you put the attachments on the teeth, then you can erupt teeth with the clear aligners. But I generally don't erupt teeth with the aligners. I'd rather put a bracket on because I'm used to it. But you can certainly do, because I know a lot of you are doing Invisalign and maybe not doing straight wire orthodontics, and you can do a lot with those and erupt the teeth. But just remember, here's the thing: erupt the posterior teeth to help the temporomandibular joint. Don't intrude the anterior teeth. If you intrude the anterior teeth, you're not moving the condyle. And if the condyle is too far up and back and they're clicking, you can make them worse. You're closing the vertical. You need to extrude the posterior teeth, and I don't care how you do it. Okay? That's my answer.
All right, next question. Next question's coming from Dr. Zive. He said, is the LPS bilateral? It was probably it was in the early part of the question, around 720. Yeah, the LPS bilateral.
The lower repositioning splint, is that what he's saying?
Yes,
LPS.
that's exactly what he's saying.
Yeah, the lower repositioning splint is bilateral, absolutely. I mean, it has to be. Now, even if the patient, let's say the patient's normal on one side and clicking on the other, you use a repositioning splint. And the one that's normal will stay normal, and the one that's just anteriorly displaced, the disc will go back in position. So yes, it's a bilateral splint, and it has to be for support, otherwise you can't chew.
And Dr. Reed, you might have just answered this, but she also asked, is the mandibular repositioning splint made bilaterally? How do you obtain the bite for the same? And maybe that's just what you just answered.
Well, I guess the simple answer is find a position where they don't click. And I hope that she saw the tongue depressor little exercise I showed, or if not, she can go on our website and your website and get the presentation we gave tonight and go over that. But remember, I put a tongue depressor between the teeth, put my fingers in the ears and have the patient open and close, and try to find a position by them moving the jaw forward or using 2 tongue depressors or 3 tongue depressors where they don't click. Now, if you have to use 5 tongue depressors, then that's obviously too much. You can't treat that patient. But if you can put 1 tongue depressor in there and move the jaw forward a millimeter or 2 and get them out of pain, I mean, that's terrific. You can't move the jaw more than 1 or 2 millimeters forward, but you can increase the vertical up to maybe 3 millimeters and make a comfortable splint. Now, I go through that in great detail, obviously in the course and obviously in the course manual. And in the course, we actually take bites on each other. It's kind of the key to the whole thing. I have a few other little tests I use, but for the beginners, just find a position where they don't click and they'll get a high percentage of success. That's my answer.
Beautiful. What splints, Dr. Podbasek is asking, what splints, if any, are used during orthotherapy?
Okay, well, what I do is I start the case with a splint, find the position that's comfortable, and then do orthodontics at the end, like I showed. That's what I did with that patient. I put her in an appliance to stop the clenching and grinding at night. And I also, now the other thing we didn't show is that appliance, that Ferrari, can be used with ortho because it has bald clasps in the front. And as soon as those front teeth are straightened, we can use that appliance during the ortho treatment to stop the clenching at night. And then, of course, the repositioning splint is used until I can grind down the teeth and bring the teeth up to the same position that the splint was in. So I do the splint therapy as the beginning of ortho treatment routinely. I do not do orthodontics on a patient who's clicking or who has temporomandibular joint dysfunction. I fix that first, and that's what should be taught in the dental school. And some are teaching it, but not very many. I mean, it's incredible to me that I believe about 80% of the headaches are coming from temporomandibular joint dysfunction, either the clenching or bruxing at night, or the dislocated disc. And physicians aren't learning about it, and we're not learning about it. We're putting flat plane splints in these patients and running the risk of making them worse because the jaw is going backwards instead of forwards, and we're running the risk of the jaw locking. I mean, it's incredible to me that this information is not made available in the dental schools. It's just so simple. I make my living on what I showed you tonight, basically, for TMD dysfunction, and it's just, I hate to say it's that simple, but it's that simple. You know, take a good history and find out what's going on in each jaw. If it's a jaw locking, you get her to someone who can treat them right away. Remember, if you've got a chronic closed lock, or an acute closed lock, when the jaw just locks, you got 5 months to find a dentist who can unlock the patient. After 5 months, it's a very difficult procedure to unlock them, and sometimes requires jaw surgery. So again, dentists should be trained not to use night guards and get those patients who are locked to a dentist who specializes in this area. And just go online and Google headaches or TMJ or in the city that you're in, and you'll find a dentist who's hopefully smart enough to be one of your clients, Don, and has got a website that can be found.
Amanda from El Paso is curious. If a patient reports neck pain or feeling that they slept wrong, is that consistent with clenching?
Well, if the jaw is in the wrong position or they're clenching, it can cause neck pain. Definitely. I mean, if it happened every night, then I would be concerned. But also, are they sore during the day? But, I mean, my patients, some of them have neck problems. They have to go to chiropractors. So in my course, I teach you how to take an x-ray of the neck and see whether you've got a normal curve in your neck or what you got going on. But a lot of times, if you put that jaw in the right position, you can fix neck problems. And I've got some patients who've been going to chiropractors for years for adjustments. And once I get that jaw in the right position and prevent the clenching at night, they don't visit the chiropractor so often. But I do work with chiropractors because if it's a real, like with a car accident or something and the neck is bad, then you do need to work with a chiropractor. So I work with ENT specialists and chiropractors, and we go through that in the course. But I mean, just, you don't have to take the course to start a case. I mean, hopefully, patient comes to your office tomorrow morning and they're clicking. Put some tongue depressors in there, find out where they're not clicking, take the impression, send to Bobby Middle at 5-Star Ortho, and start the case. It's going to be a lot better than putting a night guard in there, I can tell you that, or ignoring it. That's my answer.
Yeah, for anybody that wants to do the old school method and fax in this form, I mean, I gave you the survey online, but a lot of you faxed it in last time we did this. So I just put the handout on your sessions, on the right side of the screen. Also, so we've got a couple questions. Dr. Triana has a few, and Dr. Subservi, he also overlapped on this. They're speaking to insurance. Is this feasible for dentists accepting insurance? And then Dr. Novin's also curious, yeah, is any of this covered by insurance?
Yes, it is. In the U.S., yes, not in Canada. So you U.S. dentists are very lucky because many, many times it is covered under insurance. Even the TMJ examination and the muscle palpation and range of motion is all covered. So we have an insurance expert from the U.S. come to our course and show you and your staff how to bill for insurance. They will even bill for you and take 8%. Or they'll teach your staff to do it, and your staff does it. But so Nearman Practice Management is the company that we work with. And again, they come to the course and they have a time, an hour to lecture, because that's very important. You want to get paid. And obviously if insurance will pay, there's more patients are going to go for treatment. But I find, I mean, I'm not getting insurance and they're all paying me because I guess they're convinced I can get them out of pain. And I'm getting a lot of referrals from physicians and dentists now to help these patients. But in the beginning, yes, there is insurance, medical insurance, not dental. So that's very important because you can't bill TMD through dental. It has to be billed through medical. So it's a different ballgame. So you need insurance experts to come to my course or other courses and teach you how to do that. So they come to all my TMD courses. And now, I'm not sure, and if you take my online course, we can certainly give you their name, and in fact, Nearman Practice Management, phone us and we can give you their phone number because they're experts and they've been doing this for 20 years. You want to deal with companies like Officite and Nearman that have been around for 20 years. They're not going anywhere. They're just keeping growing. So that's my answer.
Okay, next up, in a TMD stage 2, Dr. Aldama wants to know, does the PT wear the lower index repositioning splint 24/7?
No. If you have a stage 2 internal derangement where you've got a clicking jaw, you must wear the repositioning splint only during the day, and they must wear the Ferrari or the anterior deprogrammer all night. Otherwise, they will clench on their day splint all night and they'll wake up with headaches. So if you are a clicker, you need 2. If you're a clencher, you only need 1. So I'm glad you asked that question because that's frequently confusing to people. But you have to wear 2, yeah. Go ahead.
I've got 2 people, Dr. Park and another. Is basically asking, is the Ferrari appliance similar to the NTI, and what are your thoughts on NTI?
Well, the NTI is partway there. I mean, it's called an anterior deprogrammer, and they're trying to make sure the patient doesn't bite on their back teeth, okay? But if you don't have a ramp on it, most NTIs don't have the ramp, although they're coming out with new designs all the time. I like the ramp. I like to put that ramp so the jaw can't fall back, and I like to put, in mine, of course, I put the ball class in the front, so it's a little more stable maybe. I think the original NTI only contacted 2 lower incisors, and I found a lot of patients got pretty sore, so I have them contact 4 incisors. So my design's a little different than the NTI, but I like the ramp on mine. I like the 4 class on mine. I like the air hole, so if they get a cold, they can breathe at night through their mouth. So mine is different from the NTI, but I mean, I was finding if there's no ramp, they can slide back. And you don't want the lower jaw sliding back. You've got to keep it forward all the time. So with my Ferrari or anterior deprogrammer, the jaw is forward all night, and with the repositioning splint, it's forward all day. And so therefore, I got 24-hour protection of the joint and 24 hours of relief. So you need both for patients who click.
Beautiful. Dr. Pearson has a question. Let's see. It's got a few. How long does this erupting the teeth take with adult orthodontics? And then his second question is, how much is snoring and AHI reduced after going through this treatment?
Okay, the first question is, the teeth come up about 0.5 millimeter to 1 millimeter a month. So if you've got a 3 millimeter space back there, could take 3 months maybe, 3 months. If they wear their elastics all the time, 1 millimeter a month, 3 months for that to come up. You know, it's painless, right? Because the teeth, this is interesting too, the teeth do not, the crown does not extrude. The bone comes up. The alveolar process comes up because the roots are in the alveolar process and the teeth come up, but the teeth don't extrude. So if you had a crown on the tooth, there wouldn't be any problem because the crown would still be at the gum line after you ruptured the tooth. So it's quite an interesting concept. So that's session one. And what was the second question about sleep apnea? How does my treatment help sleep apnea? Okay,
yeah, how is snoring and AHI reduced after going through this treatment?
Okay, this is not my, okay, let's say the patient snored and had mild sleep apnea. So they're stopping breathing less than 30 times an hour. And let's say they were a nasal breather. They keep their mouth closed at night. My Ferrari will work as kind of a temporary sleep appliance and will help some patients. But most oral appliances, you need to move the mandible more forward than you do with the Ferrari. The Ferrari, you're end-to-end or you've got a slight overjet. With most snoring appliances, you have to move the patient more protrusive. So my best snoring appliance, I didn't talk about that, but I think we're going to do one on snoring coming up within a couple of months. So we can, but my best snoring appliance is a two-piece appliance. And Somnodent is very, very, very popular, and a new appliance called the Narvel appliance is very popular. Again, you can contact Bobby Middle at 5-Star and you can talk to him, but I have courses online for sleep, and I've got live courses on sleep, and there's lots of good courses out there. I mean, I advise people to take more than one course because not everybody knows it all. But for snoring and sleep apnea, you need to really get an oral appliance specifically designed for that. And I like the two-piece appliance, part on the top, part on the bottom, joined together, that you can adjust and move the jaw slowly forward. That's my answer.
Okay, Dr. Zhang has a couple questions here in there. Hold on, let me order them. Okay, the reposition appliance only has posterior occlusion. Can it cause anterior open bite, thus class 2 occlusion tendency? Why not make it a full arch appliance? And
okay, that's good.
Hold on, wait. Yeah. I think he meant to say, can it cause anterior deep bite? Instead of, can it cause anterior open bite?
No, the anterior teeth don't erupt, which is amazing. The anterior teeth do not erupt. And you would think that if you had an open bite in the front, they might erupt, but they don't. So they don't erupt. They don't cause a deep bite. The bite does not change in the front. The bite changes in the front when you erupt the back teeth. So if you come in like I showed that patient, she had a deep overbite when she started. Then I put the splint in, that opened her bite, and then I replaced the splint with posterior teeth, and that kept her bite open permanently. So I mean, I'm just getting into the case, but I didn't want to go do a lot of ortho tonight. I just want to show you that ortho is an excellent way to finish your TMD cases. So if you don't do ortho, you can find an orthodontist, and hopefully he understands this technique, because remember, some orthodontists and some general dentists will open bites, and Invisalign sometimes, they'll open bites by intruding the incisors. That's not good for TMD. You have to extrude the posterior teeth. You have to open the posterior vertical dimension. That's key. That's the key to success. If you do it any other way, you're not going to get the success that I get. That's my answer.
Got it. Dr. Chess is curious how he gets his CE credit. So I've got the PDF that I've sent everybody. You can fax that in. I've also sent you the link. You can just click on that. You fill out the session. You'll get that. We'll automatically send out a letter if you put in your AGD number. Now some questions basically around, surrounding the splints. Dr. Navin and Dr. Novin. Let's see here. Do they eat with the splint is number one, and Dr. Yelazar is curious, can the anterior devices be worn for more than 6 months?
Yes, okay, so they have to eat with it, because especially after a while, remember they deal off that posterior open bite after a while. Sometimes that posterior open bite happens in a month. Sometimes it happens in 2 weeks. So they won't be able to chew unless they wear their splint. So yes, they have to wear their splint to eat. If they take that splint out to eat, you don't get the results. Because the minute they take it out, the condyle goes up and back, presses on the nerves and blood vessels, and the disc comes off. Remember, for 94% relief of symptoms, the disc has to stay on the head of the condyle. You got to recapture the disc. That's key. So they must wear it all the time. Absolutely. They have to wear it when they eat. They can't take it out. They can only take it out to clean their teeth, and they got to put their tongue between their teeth when they swallow. Their back teeth can never touch. So they either have to be in their day splint or their night splint all the time, or they're not going to get better. But most of my patients, like this girl here, she was in so much pain, and she got so much relief from those 2 splints that I guarantee you she never took them out. And if they take them out, you won't get the posterior open bite. So that's another thing you have to look for. You expect that posterior open bite to happen. Unless, I should say this, let's say the patient, their jaw was in a perfectly good position, downward and forward, with the disc in position, with a large posterior joint space and a small anterior joint space, perfect position, condyle in the fossa. And then they're in a car accident, or they get their wisdom teeth out. And because they opened too wide, and because of the car accident, the disc was dislocated. Those patients can be treated with the 2 splints, but then they won't need their day splint anymore, because the disc goes back in position, because the condyle goes back in the right position of the fossa, and they don't ever need their day splint anymore. Their day splint's done. They don't need it anymore, but I probably recommend they keep wearing their night appliance to keep preventing them from clenching and grinding. But so there's I guess there's a few cases I haven't discussed tonight, obviously, but I try to give you as much information as I can. If there's any more questions, I'll be happy to answer them.
Love it. So Dr. Rondeau, it's 8:22. Can you go to 8:30?
I'm fine. I mean, I'm
Okay. Okay.
Yeah, I just go home and watch some hockey games and some baseball games anyway.
I mean, we've got tons of questions here, so let's ask for, we'll go to 8:30 and then, or 9:30 Eastern, excuse me, and then we'll take it from there. So Dr. Forrest is curious, is the splint you mentioned the same as a tap appliance, for example?
No. The tap appliance is an oral appliance to prevent snoring and sleep apnea. And it's not an appliance designed, well, it's to be worn at night too, right? And it's a good appliance though to keep the jaw forward, because the jaw can't go back. But it's not my first choice with a patient with a temporomandibular joint problem. But it won't hurt the TMJ because it holds the jaw forward. And so it's mainly an oral appliance for snoring and sleep apnea. Again, I really would encourage all the dentists to look seriously at snoring and sleep apnea and look serious at TMD as a way of increasing the size of their practice and helping patients and wanting to practice forever, because they're so appreciative, because they can't wear that CPAP device. 70% failure rate with a CPAP device, that hose over the nose, and they're just dying to find dentists who can make them a comfortable oral appliance, gently move their jaw forward, open up their airway, increase their life expectancy by 10 years instead of with severe sleep apnea, which reduces your life expectancy for 10 years. Not to mention you get strokes and heart attacks and type 2 diabetes, dementia and Alzheimer's, and 5 times greater chance of cancer. I mean, the dental profession should be at the forefront, because we're the ones that have the solution that they want. And we should be the ones treating patients with headaches. The medical profession give them pills. The chiropractor adjusts their neck, and if the neck's the problem, it works. But if the jaw's the problem, you need a dentist. And we need to help these patients. Hopefully tonight I'm motivating some of them to, I really like the fact we got lots of good questions. And the other thing is, if we run out of time, I don't mind you emailing me, and I will try to get back within a week to answer some of those questions for you. I mean, we're here. I'm a teacher. I mean, I see myself basically as an educator. I've been doing it for 35 years, 100 days a year, which is 3,500 lectures done, and tonight's 3,501. It's crazy, but I love it. I mean, I love to help patients, and I love to help dentists learn, and I get a lot of dentists thanking me for helping them make their patients better. And
well, I certainly appreciate you, and we can sense the enthusiasm. Let's see. So Dr. Lauren Triana has got two questions back to back. Placing tongue depressors to check where the splint should be fabricated. Is that only with patients who have clicking on closing? And then the follow-up is, what about patients who click on maximum opening?
You can't help them. If a patient clicks on maximum opening, that's a late opening click, you can't help them. It's got to be an early opening click. It's got to be something that happens quickly. You can't treat those patients. Those patients, you can't treat them. They could be a surgical case. You just tell them, look, you're just going to click. Look at the pain. Like sometimes they can open wide, 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 and they're not in any pain. So they would be a stage 1, and I would not worry about them. You're going to find most patients are early opening clicks. And so you put the tongue depressor in and try to find where they don't click. So you open and close. Not just closing, it's opening and closing. Have them open and close, put the fingers in the ears and feel for the click, and then put the tongue depressor, move the jaw a little bit forward and see if they stop clicking. But you can only go a couple of millimeters. You can't go 5 millimeters forward. The splint won't allow you to do that. It can only be maybe 1, maybe 2 at the most forward. And so you got to work on the vertical. So put 1 or 2 tongue depressors in there. Each tongue depressor is 1.5 millimeters thick. You're going to find, if I had to guess, I would guess that probably 60 to 70% of patients who click can be treated with 1 or 2 tongue depressors and only move forward 1 millimeter at a time. 1 millimeter. I mean, it's so unbelievable. And the other thing I do is, of course, if that girl came in with her mother, I would have the mother put her fingers in the ears and go through the same thing I did. And when the mother hears the click go away, they buy into the treatment. They say, well, this is wonderful. I mean, yes. And I tell them, if I get rid of the click, I can give you a 94% success rate. I'm not 100, but 94 is pretty good. Where you've been in the past, you're getting 0. So 94 is pretty good. That's my answer.
Beautiful. Okay, our next question is from Dr. Fornell. It says, sleep apnea appliances are double flat plane splints. Do these cause TMD problems?
Boy, that's a real loaded question. Because here's the deal. And when I go to sleep meetings, I'm appalled at the lack of speakers on TMD. Appalled. So here's the deal. If you have a patient who's clicking, I would highly recommend that you be very careful when you use your sleep appliances. Because what happens is the jaw comes forward and they get a posterior open bite. And then how are you going to deal with that? Because the sleep appliance is saving their life, prolonging their life, improving their quality of life, saving their marriage, but yet now they have a posterior open bite. So that's a real problem. Now, you don't get that if you don't have TMD problems. You only get that if you have clicking problems. So you really have to be careful when you're using these sleep appliances. And I encourage, when I do a sleep course, I mean, I get half them signing up for my TMD course because they realize I got to know about this so I don't run into problems. Because what are you going to do if the patient gets that posterior open bite? Now they say to you, look, now my teeth don't come together. So I got a patient that happened to me. He says, like, I don't care if my teeth aren't perfect at the back. You saved my marriage, and you prevented me from you reduced my blood pressure, and I know I'm going to live longer, and I got rid of my daytime sleepiness. That's the other thing with sleep apnea. These patients are really sleepy during the day. They're zombies. They go home and they fall asleep in front of the TV. They can't play with their kids. They fall asleep when they're driving. There are all kinds of problems. So they're so happy to have a new drug called oxygen open up their airway, but they're related. I mean, the sleep and the TMD are really related. So if you're going to do a lot of sleep appliances, you really pay to take some TMD course. Doesn't have to be mine, some TMD course. Mine's a good introductory 2-day course. There's some more advanced courses you can take. Mine's really a good introductory 2-day course, which I think beginners, people just getting into this really enjoy. Try to make it simple.
All right, Dr. Rondeau, we could ask questions all night. We've got tons of more questions, but I think let's call it. I've got a list of everybody's questions here, so I'm going to give it to Dr. And he can reach out and follow up direct as well, or you've got his information right there. info@rondeauseminars.com is right there on your screen. So, if you want to get a faster answer, just go ahead and shoot an email direct. But I'll get those over to him tonight. I'm going to turn this back over to Dr. Rondeau in a second, but before I do, I just want to say thank you. Now, Dr. Rondeau, last question. What's the one piece of advice that you would like to give the audience tonight in regards to this topic?
Stay away from night guards. Don't use night guards on anybody. That's my advice. Night guards don't work for patients who brux because they bite through them. Night guards don't work for patients who click because you can cause a chronic closed lock. Night guards don't work for patients who snore because you make them 40% worse. Night guards don't work for sleep apnea. 50% of them get worse. So don't use night guards. And that's unfortunate because that's the main splint that everybody in dental school learned to make all over the world. I mean, I've lectured all over Europe. I've lectured all over the place. I mean, many, many countries. It's exactly the same everywhere. So don't use night guards. Please look into repositioning splints. Find a place where they don't click. And you will be amazed how many patients you can help with the little bit of knowledge I've been able to give you tonight in an hour. And I also really appreciate you all listening in. You're obviously the cream of the crop. There's not too many dentists that would take the time you did to listen to me for an hour and a half in an effort to try and help your patients. When you were told and scared about TMD, I'm sure you were scared stiff in dental school, because those are my smallest courses. My biggest courses are the ortho courses and the sleep courses, and my smallest courses are the TMD courses, because most dentists are scared stiff of it. They're afraid because they don't understand it. They don't want to get involved. But the point is, what you're putting in for those patients is bad news. The flat plane night guards are bad news, upper or lower, and hopefully I've been able to convince you of that tonight. That's my main message, I guess, tonight. And again, if you don't want to treat these patients, then what I'd love you to do is fill out the TMJ Health Questionnaire form. If the patient answers yes to a lot of those questions, look online, just Google it, look online, and or call my office, and we can give you the names of dentists who have taken my courses that could help, and refer your patients to someone who can help them. But don't ignore the problem, and don't put a flat plane splint in, and don't go grinding down the teeth when you really don't know what the problem is, because you're reducing vertical and you can make them worse. Everything we learned in dental school is wrong. We learned to adjust all the occlusions in cases where we didn't make a proper diagnosis in many cases, and we put flat plane splints in everybody, and they're not helping anybody. So I hope I've been able to shed some light on this very complex subject, but when you understand any subject, it's not that complex. So again, I'm just so impressed that so many of you signed up, and it would be interesting for me to find out if some of you signed up for the first one 2 weeks ago and you wanted to hear me again, because tonight was definitely different. I really thought about this presentation, and I added about 25 more photos, and I really thought about how to make this simpler. And I hope that you enjoyed it, because I enjoyed putting it together and I enjoyed presenting it. And Dawn, thanks for being the sponsor. You've helped my practice. You've helped all my dentists that you've helped, and we all need to We all need to know more about TMD. We now need to know more about the internet. And you're my coach on the internet. Appreciate it.
You're very welcome, and thank you, audience. We appreciate your enthusiasm for education. As Dr. Rondeau said, your dedication to providing outstanding patient care. With that said, I mean, make sure to reach out to Lee and Dr. Rondeau if you want some of his sessions. Obviously, tons of education here, and he's got it all, and great cases. Every time I've done this, I've seen different cases. Officite's got that free demonstration. I'm going to send you a link to that as well. And if you have any questions for us, just give us a call or email us at webinar@officite.com, and we will take care of you. With that said, I appreciate you coming out tonight, and the webinar is now concluded.
Thank you, Don. Thank you, audience. Good night.